morning, everyone. Welcome back to my IVF Answers and welcome back to our webinar tonight. I hope you prepared lots of questions because definitely the topic that we have to get to today is an interesting one, intriguing one, and also I'm sure that you will find it useful. As you can see, our special expert, Dr. Christos Roukoudis, is right here with us. Thank you for joining us tonight. It's been great to have you back. Hope you had a great day and are ready to share some of your knowledge, some of your experience, and you will be able to present the topic. PRP is definitely, I would say, one of the most interesting for the patients nowadays. So thank you for that. How are you? Hope all is good.
Hello, Caroline. Thank you for having me again. Thank you very much to be able to present also one of the very exciting topics about the PRP and about the potential usefulness in one treatment, and especially for women that are over 40. Let's see how the situation is and if it's something that we would recommend or we would not recommend.
Obviously. Perfect. Thank you so much, of course. Remember that this is recorded. We will start with the presentation. Just let me add that Dr. Christos Roukoudis is the gynecologist at IVF-Life located in Alicante. And you've been with us before, and it's always great to have you here. So if you have any questions, remember you can type those in the chat section. Dr. Roukoudis will answer them for you right after his presentation. But of course, remember, there is an option for you to get in touch with the IVF-Life team. If you have some other details you would like to share, it's also a possibility. So I think we can go ahead, start the presentation. I'm really looking forward to it. As I mentioned, this is definitely an interesting topic. So let's get to it. Okay, ready?
Ready.
Brilliant. Thank you so much.
Okay. Then, hello again from my part. We're going to speak about the ovarian rejuvenation, most precise about the PRP, and about if it's a good option for patients in advanced reproductive age, so over 40. Okay, let's jump into it. We all know that time is relative and it helps, for example, to overcome or to process things. But for us reproductive specialists and in general, regarding the desire to have children, it's the biggest obstacle. A woman around the globe postpone childbirth until later in life. Due to this fact, they are more likely to face the problem of ovarian insufficiency by the time they are ready to have children. Moreover, the tendency of the unwanted influence of environment and social factors leads to increase of incidence of early menopause, and female age, we know, remains the most important and limiting factor of success in both spontaneous conception and assisted reproductive treatment, largely to a loss of ovarian follicles and also due the impact on the quality of the eggs. So we know that already during the embryo development in the uterus of the mother, the eggs of a female embryo are created, and already then the numbers start to drop, to decrease, and at birth they drop to almost 1 million. From the graphic, we can see that from the puberty and afterwards, this process is faster, and in the time span of 40 years, more or less 500 ovulations occur, and in each ovulation, 1,000 oocytes get recruited. But in each round, only one gets selected; the rest get buried inside of the ovary. So the result is that the live birth rate, especially after 40, decrease significantly. You can see it here with the blue line, because more important, alongside to a reduction of the numbers of the oocytes, we have also aging oocytes, and those are more prone to errors in the DNA synthesis and the cell divisions, resulting in increased rates of aneuploidy, so um, embryos that have not the proper amount of chromosomes, and also congenital defects in the progeny of older women. But here we must also say that very, very important role for the decreasing in the live birth rate. Um, there are other reasons, for example, altered expression of the immune system with advanced reproductive age. So, our main goal is to enable women to become mothers with their own eggs. We saw what the problems are. So, the problem lies in the quantity, in the amount of eggs, but also in the quality of the eggs. So, we try to overcome this problem. This solution that has an excellent result, especially when we speak about advanced reproductive age, is ectonation. Okay, ectonation has a very, very high success rate in our clinic. We are, after 3 transfers, we have a live birth rate around 80%. So, but this solution can pose for some couples significant psychological and also financial concerns. Also, religious beliefs can be an obstacle for ectonation, legal restrictions in many countries. For all those reasons, the possibility to restore the ovarian function is crucial, important, and we seek for a reliable way to do this. So, the question that remains is, can the second, can the ovaries be rejuvenated? There are plenty of things proposed. Several ongoing trials are investigated approaches to rescue or regenerate the oocytes and restore fertility in women with in the menopause or with ovarian insufficiency. We have the in vitro site activation, stem cell therapies, and also others exist that put some ethical point of view topics, for example, um, the germ cell manipulation, germ cell line manipulation, and they are not justifiable. So the bottom line is that all of those are expensive, very, very expensive, complicated, and the success rates, in the end, this is the most important thing, still are very low. So an alternative as an alternative is proposed the PRP, and the PRP, before explaining it, what exactly it is cheaper, it's easier to apply, almost without risk, and from various studies, from the first studies, it seems so that the results are very promising. Now, as I said, before explaining exactly what it is, important is how we get it. How do we get it also? So platelets are small, the P from PRP platelets are small nucleoless cytoplasmic fragments derived from bigger cells. And although traditionally considered that they are the agent responsible for stopping a bleeding, this is a vessel here, what you see, and forming a blood clot, platelets, as you see here, attach to the wall and stop the bleeding, and also, but also they provide very important elements for tissue regenerating, and those are growth factors that are inside. There are over 15,000 proteins within the platelets, and growth factors are stored in the form of granules. You can see it here in the picture, and those cells, those molecules are important, play an important role for healing tissues. So um, what is in the end PRP? PRP stands for plasma-rich and platelets. Um, so it's composed of platelets in a small volume of plasma containing a high concentration of growth factors and other cytokines. And it was first used in open heart surgery, again with the same mindset to provide some cell regeneration. And it's widely used in various fields. How does the PRP exactly works? There are several explanations. The first is that the growth factors inside they activate the germ cells, the stem cells that are inside of the ovary, and so they produce new follicles. Another possible explanation is that some amount of dormant follicles is kept in the ovary, and the factors inside of the platelets can also promote the the growth of new follicles, the recruitment of those follicles. You can see here on the picture exactly how it works. So the growth factors inside, they get injected inside of the ovary and they uh, use, let's say in the neighborhood, they increase the blood perfusion, they have an influence at the hormones locally, and they provide also nutrients to the eggs inside of the follicles. Then the candidates for the PRP are women with low ovarian reserve. Here the majority are women with in the menopause, the perimenopause, with a advanced reproductive age. Then we have women with with a premature ovarian failure. So with women that came in the menopause before um, the age of 40, women that are in the perimenopause, and women that are clear in the menopause. Now, the process of getting the PRP, you see here we collect the blood, we isolate it, we separate the plasma rich on platelets, and then we take it and we are ready to inject it. Here you can see how it gets performed from our lab, live and in color. You see here the centrifugation, here the isolation, and here it's ready for application. We applicate it inside in the operating theater, ultrasound guided. This is the ovary here. The white bright line that you see here is a needle, and it's very, very similar how egg retrieval is performed. Now, we go again back to our actual topic after we understood a little bit how everything works. And I want to share with you a few studies, because the most important thing in evaluating if a treatment, and especially experimental treatment, it could be useful is to perform studies and to see if the results are encouraging or show us the opposite. So a few studies. The first study is from a group in Turkey. This study, the group that they are used here to show the results were more women that became they came in the menopause before of the age of 40. So in this group, but it's very important to see in general how it works. So in this study, around 311 women were recruited between 24 and 40, and those women were injected with PRP. Around 7% were able to conceive spontaneously. Around 64% developed new follicles before they were not able to see follicles, or were very frequent, not so frequent to see follicles, maybe one. And around 28% had no antral follicles, so the PRP didn't work at all. So in the next study, this is a study that is more interesting for our topic from today. This study is from the same group in Turkey. It's from 2022, and as I said, it's more close to our today's topic. In the study, we recruited around 510 women. The age range was between 30 and 45, and they were diagnosed with a pure ovarian reserve. They saw that after the PRP injection, around 4% conceived spontaneously, around 93% had some eggs, so they performed an IVF, and from those 93%, they saw that that almost 312, it was 66%, generated embryos and had a transfer, and from those, around 70% achieved a pregnancy, and 11% from those had like a live birth. So the most important part here is this 11.4%. And the question here is, if you see and ask questions always, that is the most important thing with those studies, is to understand if those 11%, to understand how many of those would achieve the pregnancy without the PRP. Okay, so if the PRP was really here the game changer. In the next study, there were like 8 women. They are 82 women recruited. Those women had low ovarian reserve. The majority was over 40, and they applied PRP. And from the 82 women, 46 received PRP, and the other 37, they functioned as a control group, so they didn't receive anything. They compared the results. They saw that 26 versus 5% in the control group had a clinical pregnancy. Regarding a higher AMH, so ovarian reserve marker, the group with the PRP had a higher. It was 24 against 5%. Here we must think about that the AMH has also natural fluctuations. You can measure it twice and you can see maybe a difference from cycle to cycle. Especially if we have once PRP of 0.1, then it could be the case that we see without doing anything AMH in the next cycles of 0.18, 0.2 could be. So we must have this in mind. And the most important thing was from this study is while there was no difference in the rates of first trimester miscarriage and live birth between those two groups. So the impact of PRP in this study showed not extremely high. The next study, sorry. Exactly, in this study, also PRP was performed, and we had a group of around 51% of a rather big group, around 80 patients, and from those 80 patients, 51 had an increase in the AMH. So this study wanted to see if we can see a higher ovarian reserve markers, especially AMH, after the application of the PRP and after 4 weeks. So it was the first study that showed us a significant increase. So this study summarized the for pilot studies, and in this study they said in general that PRP seems to provide some better results and increases the ovarian, and is able to increase the ovarian reserve. I already mentioned this. Here. Okay. Now, regarding this study, it involved also 38 women. They were um, between 31 and 45. All of them had a low echo reserve, and 2 unsuccessful attempts to receive their oocytes through IVF. They did 1 single PRP treatment, and the study showed a significant improvement in the hormone levels. So some of them had a a very high increase from 0.08 to 1 nanograms, and they mentioned also 10 pregnancies, and 4 of them were conceived naturally. In total, 6 healthy babies were were born. So, after mentioned these studies, since it's still an experimental therapy, there is no standard protocol. This is very important to to highlight, because this fact explains also the different outcomes in the various studies. We see a different time of application during the cycle. We see in those studies difference in the concentration of the platelets, of the platelet-rich plasma. In some of the studies, they inject the PRP more often. So also the technique is different. In some studies they do it also with a laparoscopy, so to be able to apply it better. At least this is what they claim. So in something that I want also to mention is that the clinic that I work also um, is performing a study. So the duration is set for like 6 years. We started in April. We don't have any things to announce so far. I want to explain you a little bit how everything works. So in this study, we aim to demonstrate the efficiency and the safety of the intraovarian administration of the PRP, this autologous serum, for the ovarian tissue regeneration. The candidates for the study were women that had like ovarian failure with early age, women that get in the menopause between 40 and 50, women with a low ovarian reserve, and patients with a low prognosis who subsequently undergo in vitro fertilization treatment without a low ovarian reserve. Those are the criteria. The exclusion criteria, for example, women with poor access of the ovaries, if for example, we see with the scan that the ovaries are very, very high, the PRP is very, very difficult to apply, chronic use of anticoagulants, history of cancer or tumor processes. So their obesity here is the same reason. It's because it's quite difficult to apply, psychiatric disorders or initial pregnancy. And then the difference to the other studies will be that the administration of autologous conditioned serum that we obtain from the platelet-rich plasma give us only the growth factors without other cell particles. So we will be able to achieve a high concentration inside of the ovary, and also the study will be included in the clinics where IVF-Life is present. So in all of the clinics, so we are able to do like a multicentric study. The objectives will be to improve the ovarian reserve markers and egg quality, to restore the menstruation cycle and the natural conception, and to improve the outcomes of a cycle. And how we applicate it at the beginning of a menstruation cycle in patients with regular cycles, or at any time in patients with ovarian insufficiency. And we can do it also in a setting of, you can see it here, and this is also what I used to do, especially with women with a low egg reserve and advanced reproductive age. I do first a priming, for example, with DHEA and with CoQ10 for like 6 to 8 months. Then we stimulate. During the stimulation, during the egg retrieval, I apply the PRP, the plasma. If I have eggs there, as I said, I recover them, I fertilize them, and let them develop. If we are able to do a transfer, we do a transfer, a fresh transfer. If not, with the menstruation, we wait for the menstruation, control the next cycles, see if we have a suitable cycle for a stimulation. I don't wait for the PRP to kick in, because the PRP needs at least 4 to 6 4 weeks, the earliest, but it can be also after 6 months that we see a result. So I still look for each cycle to see if we have a good cycle for a stimulation. But to see for sure an effect, we need like 3 months, good effect of the PRP, and then could be, for example, a second stimulation. Regarding the study, after 20 to 30 days after the application, we measure the hormones. We do like I do a scan to see exactly how the morphology is of the ovary, and decide the further steps. And those could be with a positive result, as I mentioned before. I don't wait. I start with a stimulation, and if I don't have a positive result, we control month per month for the next 6 months. So now, after I mentioned all the studies, after I mentioned exactly how we approach the PRP topic, it's very important to say to you that the method still remains experimental. This concerns more the patients who are over 40 and comes to our clinic with a desire to become pregnant. So these patients usually have not only, as I mentioned before, a reduced oocyte reserve, but the quality of the oocyte is also low. So we know that other parameters with advanced age influence the success of a potential pregnancy. For example, the immune system. So the immune system response So I personally have always in mind, especially these couples have a very long journey behind them with several cycles, and they're clinging to any potential hope of success with their own eggs. For all those reasons, it's particularly important to emphasize that with or without PRP, we still have a very low probability of success. This must be clear to the couple. We must communicate it very clear. All these studies, the reports success, the success that they report reflects only a very small number of patients, and this must be clearly communicated. Patient must be properly counseled and not put in a new stressful situation because PRP didn't work in their case, especially if for them egg donation is an option, um, because here we have a much higher success rate. Um, I know from many colleagues, also in our universities, that also other studies besides our study um, are running, and I'm eagerly awaiting the evaluation of the results, and hopefully will allow us to draw 100% right conclusions regarding the importance of PRP and also to refine this technique even more with time. I'm pretty sure that this is the next trend. With this, I'm approaching the end of my presentation. Here you can see, as always, all the clinics of IVF-Life, and here our contact address. So if you have any further questions, feel free to contact us so that we can evaluate if you are a candidate for PRP. And also to something else to emphasize, we will do the treatments then outside of the study, because the study is already ongoing. Thank you very much.
Brilliant. Thank you so much indeed for presenting all the data, because I think that's in the end very important for the patients to get familiar with the actual data that you have there on this particular topic. And thank you, as always. It's been great to hear what you have prepared and discussed. And of course, as you can see, there are plenty of questions right here. So yes, exactly. I knew that this is going to bring lots of questions. So thanks everyone for participating. I'm sure it's going to be an interesting Q&A. So let me get going with the very first question here. Okay, there are plenty of those. Here's the first one. Do you administer PRP over
It
rejuvenation?
depends from the case. It depends from the case. I rarely apply it without a stimulation because I want to have large, big ovaries so that I'm able to apply it properly and also have better results. But it depends. For example, if a woman is in her menopause, we can never do it whenever. If a woman has still cycles, then I would stimulate a little bit.
Sure. Thank you. Thank you so much for that. There are some questions that are really short, and so I will get to this as well. So, what speed do you use to centrifuge, I think, blood for PRP and duration?
That's a good question. I can't answer you this. I don't know this. But if you let me your email, of course, my colleagues in the lab can explain you exactly those. Can answer you this question. Sorry.
Okay. It's totally fine. I am always able to forward this question to you, your team, and I'm sure you will be able to have a look at this as well, right? I will save this
Of course.
question if that's okay and
Mhm.
forward this. Not a problem. Okay, thanks so much. Let's have a look at this one. Do you need to take the medicine?
What is the medicine?
I don't know, to be fair. Let me just have a look if Lotte has added anything here. If you can explain what you mean by that, okay, because it's hard for us to say. And in the meantime, there is another question from Lotte. What is the protocol of FSH and AMH to start PRP?
There is no protocol about it. There is no protocol. We measure it only to see where we are and where we get. Okay, so it's not like existing protocol about how high the FSH, how low the FSH must be, or how high the AMH should be, so that we can start.
Perfect, thank you. And next question is, so how long after PRP ovarian rejuvenation can one go for IVF?
This is what I said before. Because we speak about a low egg reserve, okay? Every cycle counts. I don't care if PRP in the end will start to work. It could be the case that it doesn't work. I don't put all my money, all my hope in the PRP. If I see a cycle, I monitor the cycles. I see the next cycle. If follicles are there, I start to stimulate. With a PRP, the thing that we see more often is like maybe 1 2 follicles more. It's not like that we're gonna get suddenly 20 follicles, or the ovary will become 20 years old younger. With a PRP, we can achieve few more follicles in the long run. But time is the most important thing here, and we don't lose time. We don't want to lose time and lose the potential chance that is there.
Brilliant, thank you.
Mhm.
Thank you for that question again, and thank you for explaining once again here as well. How many times can you use PRP?
You can use it more times. This is also what the study showed. It's an individual decision. I would personally, I look into the case, I speak to my patient, and we decide if it would make sense or not to apply it again. So I start first with one time and see how the response is, and then let's see how what are the results. My goal is not here to collect, X. My goal is here to have success, to have that you have as soon as possible a baby.
Understood. Thank you. And next question from Aid. Can you do this PRP for someone whose period has stopped for a few months with low AMH?
Yes, you can do that. Some studies, one study, it's interesting. I didn't saw it. I haven't seen it in the studies mentioned. Is that one menopause woman, and we speak about here are very rare thing. Okay, it's not like the standard. A woman who was in her menopause, they applied the PRP, and then she conceived naturally. I'm from my nature, I'm very critical towards everything. Okay, so you can apply it. Also, I have seen it that the cycle was after the PRP application normal for some months. So they had a menstruation. Uh, we must also, some women that have like menopause, perimenopause symptoms, like flashing symptoms, they were gone. So another potential use of the PRP could also be to treat those kind of symptoms.
And thank you for that. And how about like any contradictions of PRP?
Not really, because PRP is gained from your own blood, so that you react allergical to your own growth factors. I have never seen it, and I have never seen it mentioned from in some study or heard from any colleagues. The contradictions uh, is exactly, it's not contradictions. If I have difficulties to perform it, if I have a woman that suffers from very very high obesity, then it's quite difficult to apply it. And also, if I see that the over is very, very difficult to access them, then also we must think about how we're gonna apply it, maybe via laparoscopy. Or then if the woman has like 100 core diseases, and then maybe it's not the best candidate for PRP. So this is what I meant: individual decisions, and to see for each case if the patient is suited for PRP.
Thank you. And again, question in regards to how much time it takes to imperfect reserve after PRP.
It depends. The answer is very clear. It depends. It could be very fast, after 4 weeks to see like more follicles. It could be also the case that after 6 months, 7 months, and this is how I see more often. That after 6 or 7 months, I see few follicles more.
Of course. Thank you so much indeed.
But it follows
Mhm.
from the idea. From the idea, the PRP starts to work, or we're gonna see the results of a PRP normally if we know the physiology of the how the ovary and the recruitment of the follicles work after 3 months, because the eggs that you have now in this cycle were recruited 3 months before. So if I apply it now, then in 3 months I'm gonna technically I would see the impact of the PRP.
Okay. Thank you for that. Okay, next question is here. Can one get HGH as well as having PRP?
H.
I'm not sure as well here.
Human
So
growth hormone.
if
Okay. Oh, you saved us.
human growth
You saved us.
hormone.
Yeah, yeah,
Yeah,
yeah. Site
thank you.
10, for example, I gave it, I give it the only study that is quite reliable regarding the human growth hormone, said or described the application, and this is how I do it during IVF treatment every second day: 0.1 milliliter, 5,83 milligrams.
Mhm.
Yeah, we
Okay,
can do it.
brilliant. Thank you. Do you test the immunes as well?
Of course, yeah. I test the immune system is a very, very important player for success, for deliver a healthy embryo. We know that the immune response during our life changes, and especially regarding a pregnancy. After the age of 40, the response is different. Before, some years ago, or also now, many colleagues claim that the reason for a miscarriage is, of course, that the embryo is not okay. It's not true. We have as we have seen from, it's another topic, but very fast, that PGTA is not like the solution for all of our problems, because there are also other problems that plays a role. Immune system, the alteration in the immune system must be also treated individual with a proper um, uh, guidance of immunologist.
Thank you so much indeed for yet another question here. Okay, there are like question in regards to cost of PRP. Are you able to tell us more or less?
Um, I can't contact the clinic, and they will give you exactly a picture of what you expect. I know, cost,
Yeah,
cost, cost. Sorry, guys, sorry, but
of course,
I think
that's understandable.
my colleagues will explain, my assistant will explain to you much better than I will do.
That's
I
perfectly
promise you this.
okay. Exactly. I have
Yeah.
just put the email address you can use, contact@ivfspain.com. This is where you can ask the question in regards to the cost. And let's have a look. There are some other questions here. So, what are your views on LIT and IVIG for immune issues? If you can help with
Yes,
that.
yeah, EVIC immunoglobulins, it makes sense, but not to all the patients. We look what the how the various white blood cells that physiologically lives inside of your lining, and in some cases in your blood, also behave, how the populations are, if some of the population of white blood cells is overrepresented, and then we see if you're a candidate for IVIC or other medication, like tacrolimus, like hydrochloroquine. There are various things, but customized, everything customized, not like okay, the neighbor did it, okay, the neighbor patient had it, okay, it will not harm us. It will harm us, of course. We will not do it to every patient.
Of course, that makes perfect sense. I missed one of the questions. Sorry about this, but of course, here it is. Does PRP make sense for women with low equality, AMH, FSH, AFC are still okay?
Look, Jen, uh, it depends again. It depends. Nature doesn't work 0 or 100%. There is a gray area. It's not like that one woman produces only unemployed embryos, unhealthy embryos. This is also the big trap of PGTA testing. So, if the question is has more to do with low fertilization rate or a low maturation rate, it could be, yes, that PRP can we can have a benefit out of PRP. If you want, share me your case, and I will contact us, and I will can give you like individualized opinion about if PRP would make sense. Low blastocyst, look, low blastocyst rate also is a matter of debate. A woman with a low egg reserve doesn't benefit for a blastocyst transfer.
All right, thank you so much. And as Dr. Roukoudis said, if you wish to get some more details, you can get in touch. I'm sure they will be happy to help you even more. And thank you for all of the questions so far. There are some more coming up. Let me go to the next one from our next patient. Besides PRP, is there any evidence that other methods taking NMN, CoQ10, vitamin D might be successful? And what is the upper age limit?
DHEA is helpful, of course. Also, there are plenty of studies. I give like 75 milligrams. So one pill contains 25 milligrams. I give 3, and I give it for like 6 to 8 weeks. After that, I start with the stimulation in patients with a low egg reserve, and together with DHA, I give also CoQ10. Not the expensive stuff. You don't need the expensive stuff. The pharmacists will not love me, but you need the normal stuff. And after 6 to 8 weeks, we start the stimulation. About the NADH, there is no study, but it makes sense. If you want to take it, it's inside of many compounds. You can take it also. It will not harm you. And about the upper age limit for what? For the PRP application, I would not recommend to you with 50 to have the PRP, to be honest. I would rather recommend you to think about if ectonation would be a better option.
Okay, thank you for your question and clarification to those as well. Okay, next one, Sebastian. Is the PRP created individually for every patient, or is it designed?
No, it's maybe it's my mistake. Maybe I didn't clarify it before. So the woman comes like before the application of the PRP. We drain the blood, we do all the process, the centrifugation, everything that I showed you, and then we apply it inside of the ovary and the ovaries. So it's from the own blood, the blood from each patient. It's not like that you're gonna have something from Walmart. It's from every patient, from each patient, their own blood, their own growth factors.
Thank you for the clarification here. Gabriela, another question. Interesting. Can PRP be combined for both ovaries and endometrium, and can this be done simultaneously?
It can be done, yeah, but because we need like a rather high amount of blood to drain the PRP, I tend to do it always at one of both. But yes, technically you can, we can combine it.
Perfect, thank you. And Sebastian has one more. Is it also possible to give PRP via intravenous infusion?
I would not give it because you don't achieve what you want. You can't achieve the higher concentration in your ovaries. If you want to become younger, I think their cosmetic surgeons will be in general younger. PRP if intravenous will not be helpful.
Okay, thank you for that explanation. And would PRP have better results with donor plasma, say plasma from a woman in her 20s?
Um, this is an interesting question. Um, um, there is no data regarding this, but it would be the blood, like a blood transfusion in the end, because you take like blood from a different person. So also you carry some additional risks. Um, from my opinion, I would not expect a better result because you have still the growth factors, and they're the platelets, so you don't have a lack of quality with age in your platelets. But there is no study about it, and also I would not do it. I would not do this, to be honest.
Understandable again. Thank
Because
you
also
for
the
that.
also
Yeah,
the PRP is experimental treatment. This is even more experimental.
exactly. Thank you so much, though. Of course, you always bring very interesting questions
But this
indeed.
is a
So
very, very
thanks.
good question. Very, very good question. Bravo, bravo.
Thank you. Thank you for those questions for sure. Okay, and let's have a look at this one. I learned you can use PRP to improve the thin uterine lining. Is that true? Do you do this?
The idea is quite the same. So the growth factors inside will have an impact inside of in the lining, and the endometrium can be thicker. Yes. So we have also a protocol if we have like therapy, hormone resistant endometrium to apply PRP, and in some cases we see an improvement. Yes, and we do this.
Thank you for the clarification again. How about this one? Can PRP improve the quality of oocytes or only quantity?
Um, it's more the quantity. It's more the quantity. Uh, the 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 the, the influence in the quality is lesser in comparison to quantity. Okay, so more it's a matter of quantity, more follicles.
Mhm. Okay, thank you. There are like three questions left, so we will be slowly finishing. However, if there are more questions you would like to, if you have more questions, go ahead, type those in. And let's have a look. Derek has another one. Do you believe PRP is different from ovary stimulation post injection?
It's different from overstimulation. From overstimulation. I didn't understand the question. I must admit.
Yeah, if you can help with that, explain a bit what you mean by that. Post stimulation, right? Post injection, I think. Per PRP versus poking the ovaries
Yes, this
in
is this is
general.
this is a good question. So the people they criticize the PRP, and I'm also not 100% convinced. They say that with the poking inside of your ovaries, maybe you trigger some process inside of the ovaries, and the ovaries start to work more. And this is what all those studies must 100% clarify, because I would never take a woman and to all of those to poke in the ovaries like this without applying anything. The idea of the PRP, because in other fields of medicine, also in other fields of medicine, has shown some importance, is to apply it in the ovary and have a better results. So uh, yes, but I'm not 100% sure if the poking of the ovaries is maybe the main hero here in the end. Okay.
Derek, thank you for that question as
Thank you. Thank you.
well.
Thank you.
Definitely interesting questions are right here. There are more. Okay, there are more like that. Here, one more. Can PRP change embryos chromosomically? I
Mm,
guess.
um, it's a complicated topic. As I said before, nature doesn't work 0 or 100%. Okay, so not all of your embryos. This is a problem with the whole PGT-A testing, is that many women are traumatized that they did like a cycle, have like 5 embryos, were tested, all of them unemployed. So the conclusion is I produce only chromosomic abnormal embryos. It's not, not true. For if if, for example, a karyotype was performed before and we had like a look in the chromosomes, and the chromosomes, everything was okay. So one reason more that a woman doesn't produce only unhealthy embryos. So coming back to your question, uh, the X could have an abnormal amount uh, of chromosomes. The PRP cannot have a direct um, impact in those eggs, but maybe some more eggs will appear, and in those eggs, the chromosomes will be okay.
Thank you once again, of course, for that. How about this question? What is the maximum BMI to qualify for PRP?
Um, I don't know exactly what's the exact weight, so we don't put the girls on the women, the girls on the to measure the weight. We um, do a scan, we see if the ovaries are accessible, and then decide if it's possible or not.
Makes perfect sense again. Thank you so much for that question. Well, now, Sebastian, your question might be our final question, but of course, remember, if you have more, you can definitely get in touch with the team as well. And let's have a look at this question. Is it useful to administer PRP to Asherman syndrome patients? Is it indicated into the uterine cavity in this case? I think.
Mm, yes, it is. Asherman syndrome is a very, very uh, difficult diagnosis because the lying is therapy resistant. There is, in some cases, a very low amount of functional endometrium tissue there. So PRP is then one of the main assets that we have to improve, to try to improve the the endometrium, the lining, but still in many cases we are not able to do it.
This is still something that we need to wait for more studies, I guess, right? And
It's very
just be
difficult.
sure. Yeah, just to be a bit more sure and sure that it's actually going to work in the end, of course. Yeah.
A stem cell
Well,
therapy would be there. A stem cells therapy there, or would be is also a possible approach.
mhm, okay, thank you. One more question showed up just now, so I think we can still answer. Sorry, is insemination an option after PRP or exclusively IVF?
Of course, it's an option. You also can try to conceive naturally. So whatever you want.
Mhm.
In some of the studies, some natural conceptions were mentioned. So technically, you could, of course.
Again, it's about individual case, right? Every patient might get different result as well. Yeah, we need to remember about that. Thank you so much again, and I believe that we will be finishing for tonight. As you know, if you would sorry, one more. Sorry about that, just right here. Thank you, Tina. Is it possible to make PRP in the uterus? Does it increase the chances to get pregnant?
There are not reliable data exactly to how PRP can increase the chances, but we apply it inside of the cavity, we apply it inside of the endometrium, especially in cases where we have implantation failures. So uh, it's something that we can consider to do. For example, if we have like a lining that is like it must not be, Asherman syndrome where the lining is very, very thin. It could be also a lining where of 5 millimeters. So then after, I don't tend to give, all the medication of the world, all the hormones, all the estrogens, the highest dosage, and increase also the risks of having a thrombosis. I try also to apply the PRP to see if we can achieve a better lining. So there it has also its place.
Sebastian has one more question. For improving the lining, is PRP administered into the uterine cavity?
I rather inject it inside of the cavity. Don't I don't do, we can do also flushes, to flushing it inside of the cavity, but I'm not a really fan of it, to be honest. I rather apply it. So with a small needle in the hysteroscopy, I search for the areas where the lining is thin, and then I apply it. So
Okay.
controlled and very, very organized, and not like only flashes.
Understood. Thank you, Sebastian, for follow-up here. Derek, one more question from you. Thanks for that. Do you think PRP is similar to mitochondrial injections, just different version?
No, I didn't. I don't think so. I don't think so because here you deliver growth factors, and then in the mitochondrial injections, uh, it's also genetic material. It's like uh, sDNA. So it's something different. Both of them are injections in the end, but it's different. The what we inject.
Okay. Thank you so much indeed. And thank you everyone for your amazing questions. That was very definitely intense Q&A session. Thanks so much for that. And of course, interesting for sure. This topic is definitely, as I mentioned, hot topic, and you see it if you look at the questions, you know it. As you can see, Dr. Roukoudis, there are this is a previous questions. There are some thank yous coming up your way. So no question, just a thank you, Dr. Roukoudis. Very interesting
You're
topic.
welcome. Thank
Good
you very much
information.
to listening to
Thank
me.
you.
Thank you very much.
Thank you so much, everyone, for joining us. There are so many of you from very different places all over the world. I can honestly say that. So thanks for joining. Thank you for your questions. And thank you, Dr. Roukoudis, for your expertise, for helping out with all the questions, of course, as well. As you can see, many things are coming up right here from various places. We have someone from Brazil. Hi, good to
Hey,
see you here.
how's the weather there? Better than here?
I'm sure. I'm sure. So Sweden. Okay, nice. Thank you so much. Liverpool here. So as I mentioned, many different places. So it's amazing that you are able to
Nice.
join us and ask your questions. Ireland, nice. Thank you and welcome. And I hope that you will be able to join us. As you know, there are plenty of more webinars coming up. Some more hopefully interesting topics for you. And Dr. Roukoudis, it's always a pleasure to have you here. So thank you. You are always amazing. It's a pleasure to cooperate. So I would
Very
like
much.
to ask you if there's anything you would like to add before we finish.
Also, thank you very much for having the opportunity to explain a little bit a topic that is a hot topic at this moment because it's offered it's offered more and more. Uh, but I want only to emphasize the one thing that I said that if it doesn't work, because the possibility that it will not work is quite high. It's quite high. Uh, don't put all your hopes um, put not all your hopes in the PRP. We can do it as something additional. That's the reason why I like to apply it during a stimulation and use the further cycles. I don't wait for the PRP to kick in. So don't be discouraged. It's not like that with your body something does not works well. It's PRP still is experimental and still uh, will not be always, or in the majority of the cases, not the solution. So this is what I want to add, and it's very important for me to that my patients have this in mind.
Thank you so much for adding that. This is something definitely everyone should remember. Thank you, everyone. As I mentioned, it's been recorded. You will have a chance to have a look at this tomorrow. It will be available on our website, myivfanswers.com, but also our YouTube channel. I can only encourage you to simply subscribe, and that way you will be notified. But also, if you would like to check some of our upcoming events, you can go to the website there and just sign up, and I'm sure it's going to be interesting for you. Thank you, everyone. Have a lovely evening, Dr. Roukoudis. A great pleasure. Have a great evening as well, and I do hope to see you sometime soon as well. Okay, take care, everyone.
So
Thank you. Good night.